and start the webinar too.
With you, I don't have the blue button saying to start the webinar anymore. I think
Okay,
someone
I'm
started it.
starting it. I'm
Okay.
starting.
All right. Good morning. I think we're live. Uh, my name is Kleber Fertrin, and I would like to welcome everyone to this first virtual webinar for sickle cell patient and caregiver education. Today, we're going to focus on transition care management, and I would like to first apologize to everyone because originally this was meant to be an in-person event, but we had to change to a virtual format instead. But in any case, we're hoping that we have the opportunity today to talk about a few aspects of sickle cell disease that are important for transition care management for patients who are transitioning from the pediatric clinic to the adult clinic. And we're hoping for a good discussion. Please feel free to ask questions, to interact with our speakers. This webinar is also being recorded, so we will be releasing links to the recordings so people can also rewatch and also share with other patients that might have missed the event. So with that, I would also like to introduce my co-chairs for this event. So I'm the director for the Adult Sickle Cell Disease and Iron Overload Program at the Fred Hutch Cancer Center and associate professor at the Division of Hematology and Oncology at the UW School of Medicine. This event was organized in collaboration with Alex Dassler, who is the APP clinical lead at the Comprehensive Sickle Cell Clinic at Seattle Children's. Unfortunately, Alex will here because she's on maternity leave. So I also had the excellent collaboration of Angela Leo-Nkoah, also an advanced practice registered nurse at the hematology department at Seattle Children's. And I'm happy to have her here today with me, co-sharing this event. Before we continue, I'd like to go briefly over our agenda for today. We made it really short because we also understand that being a virtual event, it gets really tiresome over time to follow all these presentations. But essentially, we have four different talks we planned for today. The first one is going to be on mechanics of transition, so more about what exactly we're talking about, what transition in care management. Then after that, we'll have a talk more focused on mental health. We understand that mental health is a big part of the management of sickle cell disease, and it's also an area in which transition creates a lot of complexity in transitioning. Essentially, no one likes to change providers, for example, and change treatment centers. So we understand it's important to know aspects of mental health and what resources patients have access to. Then I'll talk about disease management, trying to give a wide overview of the treatments we have available for sickle cell disease and newer developments that people have heard about gene therapy in particular. And finally, last but definitely not least, we're going to have a talk about emergency department experience. So how treatment of sickle cell disease happens in the ED and differences when patients transition from pediatric to an adult setting. We will, I think we'll give a few more minutes for people to join, but then I think we'll get started. This is just a few reminders about how the webinar is going to happen. As I said, this event is being recorded. Please feel free to post your questions using the chat function. myself and Angela will be monitoring the chat, and we'll make our best effort to address all questions. If we happen to be unable to answer any questions that are posed through the chat function, we can always get back to you after the event. Another reminder that if you end up accidentally leaving this webinar, you can easily rejoin by clicking the same link that was sent to you upon registration. There will be no need to re-register or anything like that. And after the event, we will send a feedback form, and we really encourage people to fill in these event feedback form that allows us to get a better idea of what we can improve in future events. Since transition care management is an ongoing issue for many patients and it takes many, many years to happen, the idea is that this will not be a one and only event. And our intent is to continue to promote events like this, addressing all aspects of transition, and also just organizing events that will educate people about sickle cell disease in general, and all aspects that are important to the treatment of these patients. Okay. Let's see what time it is. Yeah, we still have a few minutes until the plan. Maybe what I propose, we'll give maybe a couple more minutes, Angela. And since this is recorded, and I think we're still having some people trying to join, after that we can start. Is that okay?
Yes, I just restarted it.
All right. So for our first talk, we'll have Angela talk about mechanics of transition. So Angela, take it away.
All right. Thank you, Dr. Fertrin, and thank you everyone for being here. So talking about mechanics of transition, what is that? So it's basically like what goes into transitioning a patient from the pediatric setting to the adult healthcare system. And so I'll give a few definitions or two that were selected in terms of what transition is. And because it's definitions, I'm going to read them. So the first one is, this is the purposeful planned movement of adolescents and young adults with chronic physical and medical conditions from a child-centered healthcare to adult-oriented healthcare system. And the other definition is the process of moving from a child or family-centered model of healthcare to adult or patient-centered model of care, with or without transferring to a new clinician. So the part of the last bit of the second definition, talking about whether moving or not moving to a new clinician, comes in when a patient is being seen by a primary care provider who is family care oriented, and so they may not need to transfer. But for our purposes, we are going to stick to the first definition, and so that's what we're going to do it. So next slide, please. So with the first definition, it talks about transition being a purposeful process. Why does it say this? This is because usually at the time of transition, patients are experiencing increasing life and healthcare changes. We know in sickle cell disease, once patients start to grow or get to adolescence or young adult ages, conditions tend to change a little bit where they may experience more complications, which may lead to them having some mental health issues as well. So all that may lead to increase in patients' admissions or ED visits. Again, a research has found out that lifespan is shortened by about 20 to 40 years as compared to the race-matched counterparts around this time frame, which is very, very sad. And then again, around this time, there is assumption of responsibility of care. So we know that patients from this age are taking more responsibility about their own care. They are calling for to schedule appointments. They are calling in their refills. They may actually start driving. They may be entertaining some new jobs and stuff like that. So overall, this time becomes a bit stressful and coupled with transition. So it has to be like a purposeful process. The other piece is that inequities intensify, and it's both structural and interpersonal mediated racism and stigmatization. So when kids are really young and they're coming to the hospitals and stuff, they are coming with the parents, caregivers who may face these things for them, but then at this age, so it becomes a situation where you have to be purposeful in terms of your process. Next slide, please. And so in terms of transition, how do we do this? There are national guidelines and frameworks that help guide how we transition patients to the adult world. And again, because of all these things that we've mentioned, we have to do this in a way that is, in a process that will help do it successfully. So talking about three guidelines that are in place. We have the Sickle recommendation, the One From Association of Maternal and Child Health Programs, and then a combination of these two. And so we'll talk about each one of these separately. So next slide. So with the Sickle recommendations, it talks about skills transfer. So these are recommendations that people are supposed to use to guide how we transition patients. So skills transfer is where you teach the necessary transition skills in terms of how do we manage pain at home? How does the patient schedule the appointments? The next piece is increasing self-efficacy. So after you've done these teaching, you have to increase the patient's ability to manage their own disease. With all this, you need some help. How do we do this? We have to coordinate the transition. And this is supported by trained community health persons or nurse navigators to help with all these teaching and then building of these self-efficacy. And then the knowledge transfer. So programs are supposed to develop a curriculum or a handbook that will facilitate this education. The other piece is we don't just see the patient and just push them into the wild. We have to link them to adult services. And then with all this, you have to evaluate the patient's readiness, because if they're not ready, of course, you cannot do this. So that is a Sickle recommendation for how to transition a patient. Next slide. Then with Association of Maternal and Child Health Program guidelines, so this is divided into two parts. There is the pediatric standards and then adult standards. When it comes, and it's both 4 in number. So talking about the pediatric standards, so it talks about transition policy. It means a program should have a policy in place that is developed with the assistance of patients and their families. And then the policy should also have the privacy and consent part of it, and then you have to tell them where these apply. And then when does this get started? Where do we start transitioning patients? So the discussion should start from the ages of 12 to 14. The next piece of it is transition readiness. So this is where you actually score a patient's understanding of their healthcare and their self-care in general. Scoring tools for this. And then a transfer of care. So this is where you provide all these clinical documents that the patients need to transfer to a different provider. So this could be an updated plan of care. It could be the emergency care plan, cover letter, all those things. And then the transfer completion. So this is where you confirm that the patient has actually been able to transfer to adult provider, and you continue to provide that care. So between the pediatric provider and the adult provider, there should be a consistent communication to make sure that everything that is required is provided. Now, next slide, we'll talk about the adult standard. And again, so the adult standard, again, is in 4 standards. So the first one is, again, there has to be a policy on the adult side of things. And this shows the approach to accepting and partnering with a young adult in terms of their care. And again, it's developed with input from the patient to make sure that you are actually discussing what the patient needs. So during the first visit, this is discussed, and then regularly on an ongoing basis, you discuss this as well. The next part of it is orienting to or integrating the patient into adult care. So here, again, you know that for you to transition successfully, there should be providers that are interested in taking care of patients with sickle cell disease. And so there should be a list of providers that are ready to take on this responsibility. And then for the initial visit, the guidelines tells us that we have to address their transfer concerns. What went well, what didn't, how can we do it better? And then clarify their care approach. So the adult system will have to let the patient know how they care for their patient. And then you conduct a self-care assessment to see where they are in terms of their self-efficacy. And then ongoing care. You have to make sure that you communicate as before with the pediatric practice in terms of confirming that the patient has actually transferred to the adult system, and then to help them connect to any kind of adult specialist that they may need or support services, and then support ongoing development of their self-care skills, because at the time you are not convinced or you may not be sure that the patient is actually able to take care of everything concerning their health care. So you have to do like a support on an ongoing basis. And then you get a feedback about how the healthcare experience is going. Next slide, please. Next slide. So with all these guidelines in place now, how do we tell if a transition is successful? So unfortunately, there's no established metric to define how sickle cell transition is successful or not. But there's been 54 concepts that have been grouped into 4 main concepts to let us know that, okay, this defines how a successful transition is. 1, structure. There should be infrastructure where the patient is actually being seen, or a sickle cell disease facility where the patient can be admitted or seen outpatient. There should be capacity for healthcare transition. So in terms of, do we have providers? Do we have other people in the team that can help with this whole program to be successful? Process. And these things will let you know if the transition is successful or not, because if you don't have the place to see the patient or to admit them to, how can that be successful? Process. So these are the clinician activities that are geared towards transition preparation. So as we talked about the policies, are they going by it? If you have a policy that is being adhered to, that will let you know whether the transition will be successful or not. And then outcome. So care utilization. After all that work, is the patient able to go to the clinic? Are they actually utilizing their care system? Are they going for their outpatient appointments? Are they going for ED visits or things like that? Are they coming in? And then how much does this cost to the patient? If they're not able to utilize care, of course, it's not successful. And if the cost is so high for the patient, they will not be able to transition successfully. And then mediator, that is the factors that facilitate or hinder the process. So these are things like care coordination and then patient characteristics. And we'll talk more about this. So in terms of things that will hinder the process and care coordination, so if there is no team that will support this transition, it may not be successful. If the patient has some characteristics in terms of what is happening to them, depression, it could be like a mental illness, it could be pain, it could be complication from their illness, that may not facilitate the successful transition. Next slide, please. So continuing, so after those 4 concepts, there are other concepts that have been developed. One is looking at elements of other chronic diseases. So example, cystic fibrosis, how do they do their transition? We can pick up elements from there to guide your own, to tell you whether yours is successful or not. There's been other measures that have come up from surveys from sickle cell disease experts, and these have been divided into the patient level and program level indicators. And we'll talk about this briefly. So in terms of the patient level indicators, it's mainly the disease status of the patient, like how severe the disease or dysfunction is. Because if it's getting severe and disease severity is just worsening, then transition may not be successful, because who is able to continue with this care? If we don't have that, it means the patient may have more severe illness. And then patient-centered outcomes. So things like health-related quality of life and satisfaction. Here, how is the patient enjoying their life? Are they still able to play their role in their community, in their environment? What is social functioning? Are they able to still be students? Are they able to be employees and be able to participate as they are supposed to? If transition takes place and is successful, then they're able to continue their life as usual. And then achieving important life milestones, things like post-secondary school education, are they able to pursue that? Marriage and things like child rearing, how is that going? All that will guide you to know whether the transition was successful or not. Next slide. Continuing with the patient level indicators. So patient-centered outcomes, more of these is the patient's health literacy and disease-specific knowledge. So if you are able to adequately teach, training the patient to understand their health and disease-specific knowledge, then the transition would have been successful. If not, then it tells you that not successful. Self-efficacy, are they able to participate in preventive care, medication adherence, ability to call and schedule for the appointment? All these things will guide you to know whether the transition was successful or not. And then satisfaction with transition. Patient will let you know how this went. Went well, it didn't go well, are all indicators. And then trust between the adult provider and patient, very, very important. If the patient doesn't have trust with the provider, of course, they are probably not going to even go to these health facilities. And that will let you know the transition wasn't successful. Next slide, please. Patient level indicators, again, continuing. Transition readiness. As we mentioned before, this is based on self-management skills readiness checklist, or the transition intervention program readiness for transition assessment. So these tools would let you know how well the patients understand their disease, how well do they understand the care management, and will make you tailor your teaching to specific areas that you find weakness in. And so all that will help you have a successful transition. And then healthcare utilization, as mentioned before. So this year is the completion of the first visit, and we expect this to happen within the first 6 months after leaving the pediatric care. And then retaining in the adult care system. So care should be retained for 12 to 24 months or later, and then the frequency of emergency department visits or inpatient visits, all these will guide you to know, was this transition successful or not? Again, as we mentioned, if the patient sustains visits to outpatient clinics in 12 to 24 hours months, we know that the patient's transition was successful. If you're having a lot of admissions, it may not have been successful because the patient may not be doing the things that they need to do to help reduce these frequencies. Next slide. And then the program level indicators is one main thing. What is the outpatient sickle cell clinic doing to implement their transition activities? And so there are guidelines that are in place, but are they utilizing these guidelines? And if they are they using metrics to determine how well these are being utilized? So at the program level, you're actually assessing how well these program guidelines are being used in terms of transition, and it kind of guides you when you monitor it to know how effective or not effective they are. Next slide. All that being done, we have all these guidelines, we have how to have transition successfully, but what are the barriers to a smooth transition? The one main thing is systems of power. This is racism and sexism that are embedded in our healthcare system. All these things prevent patients from coming in as they're supposed to. So things like patients may not have a good relationship with the provider because the provider may not be comfortable seeing a patient, probably because they are just having particular challenges with the provider's bias, or they may not even have access to health insurance. So all that would limit their transition to be smooth. And then limited number of capable providers for adults with sickle cell disease. And so we may have providers that have a lot of knowledge about sickle cell, but are they ready to build that trust that is needed in order to have a successful patient relationship where they can discuss their pain and their management freely with the provider? So all these things are limited, and mainly because sickle cell disease management is complex, and there are a lot of providers that may not want to do to be involved in this, and so it causes a barrier to a smooth transition. Other barriers is the negative interaction with emergency and primary care providers, and this has been studied, and there's been so much literature about that. And so this issue brings about cycle of mistrust. And for the young adults or the adolescent who is considering transition, this may be a problem for them. And so it ends up being non-adherence. They may self-discharge from the hospital, or they may avoid the health system altogether because they don't want to deal with this. Next slide. And then continuing, so low transition readiness is another barrier. And this has been shown in surveys where kids younger than 16 years old have been shown to have low disease knowledge and interest, and they have higher disease severity, which is associated with low interest and greater anticipated difficulty. And this has been found to be due to having fear of leaving their providers that they are used to, or the healthcare facility that they're used to. The other thing is they're just afraid to go to a new person. They don't know if this person is going to trust them. So all these things lead to low transition readiness. They don't want to even engage. And then cognitive disability and depression. We know that in sickle cell disease, it can cause strokes, it can cause cerebral infarct, and then sometimes there may not be an injury or anything, but it's been linked to neurocognitive findings that can impact education and employment. It can as well impact and stuff. So it makes it hard for a person to learn the things that needs to be learned, take charge, and transition successfully. So decreased cognition, as we said, can affect their health literacy. They may not understand their own health issues. They may not understand the health system really well, which can again result in fear and mistrust, and they may not want to even do it. And then depressive symptoms can further affect cognitive functioning. So all these things are barriers that need to be addressed. Next slide. So with all the barriers that we've identified, how do we transition? How do we provide things that can help transition successfully? How do we intervene? There are overarching principles that can help. One, we should consider all aspects of care when we are considering transition. So education, employment, home life, and community. How do we do this? By having an interdisciplinary team, including nurse educators, including clinicians, psychologists, social workers, that will help coordinate all our care. So academic liaisons, community peer navigators, because we cannot do it just at the hospital or at the clinic. We need a community as well, so that we can address all these aspects that affect transition. And then it should start early. So all these guidelines that we talked about starting from 12 to 14 years old. And so these principles need to be applied. So start early to gain success when the patient is actually ready to transition. And then we should be flexible with accommodating patients' cognitive challenges, as mentioned before, because severe sickle cell disease can actually have all these implications on or impacts on their cognitive abilities. And so when you're thinking of transitioning, we have to consider that as well, and not just say the patient is at this age and should be able to understand this. It takes time. We have to be flexible. Next slide. And then continuing. So with the interventions, there is this element called the 6 core elements of care, which is developed by a center that is federally funded to develop these resources for patients and their families to help with transition. So going by these core elements, we talk about transition policy, as we've mentioned in the past. So we should provide information about the process and discuss with the patients and their families starting from, again, from the age of 12 to 14 years old. We should track and monitor this patient's progress. So again, from 14 to 18 years old, all the things that you have in your policy in terms of giving them the skills that they need, training them, you have to keep monitoring, acquiring this knowledge and skills by doing regular checklists and then comparing it to the data to find out how are you achieving transition? Are they ready for transition? And then transition readiness, as mentioned, these assessment tools are used, and it could be a sickle cell disease specific assessment tool, or it could be other generic ones, but you are assessing whether the patient understands their phenotype, they're understanding their pain plan, understanding emergency care. So all these things play into you planning well for the patient's transition. And then transition planning. So as we mentioned before, it should integrate the cognitive assessment part of it. And here providers and families have to work together in able to be able to identify where the patient's weaknesses to transition successfully. This will help you know what the patient's knowledge is about sickle cell disease in general and their healthcare skills. Next slide, please. Then continuing the elements of care, so transfer to the adult care. So this should happen, again, as we mentioned, within like 6 months. So 2 to 6 months, we should expect that the patient should have visited the adult care clinic after their last pediatric clinic visit. And then integration into adult care, this typically is completed between the ages of 18 to 26. Again, we have to be cognizant of the fact that we should be flexible, because it's not every patient that will be able to do it successfully at 18 or at 20. It takes time. And then it should occur when the patient has an adult provider. As I mentioned previously, once you think that the patient is at this age, you just don't push them into the wild. They should have an identified adult provider to continue care. And then once that is done, you confirm whether transition has actually taken place as the patient had their first visit. What impeded the progress? Why couldn't they do it? And then you obtain feedback once the patient actually successfully transitions, so that you'll be able to use that to guide your next step. Next slide, please. So talking about all these interventions and things we can do to improve transition, there are resources available for patients and their families, and these are listed here. So the Healthy Children Organization is from the AAP, and it has all this information about everything you can think of that can help your patient or your family member. And then the Sickle Cell Transition e-learning program developed by St. Jude's. It has a whole bunch of educational models to help. And then Health Smart is also an online brochure from St. Jude's Research Hospital that has all this information to help us transition effectively. And then GOTS Transition, which is a national resource for healthcare transitioning. And then the CDC also has a Taking Charge of Your Health and Healthcare, which is a sickle cell disease transition process for our patients. Next slide, please. And then for providers, we also have these to help guide how we organize or go with or go by transitioning our patients. Next slide. And then my last slide is about, this is the last one, it's about Seattle Children and how we approach transition. And before I go into it, Seattle Children is still working on developing a very robust transition program. But for now, this is what we have. And just so everyone knows, it's a work in progress. So for us, we start giving information about transition process beginning at the age of 11. And then between the ages of 14 to 18, or annually, we complete the ASH readiness assessment. And as per the guidelines indicate, once we complete that, it tells us where the patient has strengths and their weaknesses, and then we tailor our teaching accordingly. And then again, within that same age range, we build the skills that we think our patient needs to transition effectively. So things like, are they able to request for their own refill? Do they even know their medication? Do they know what the medication does? And then how are they able to make appointments or reschedule if it needs to be done? At the age of 18, we discuss medical consent and privacy. So here it's more about letting the patient know, now you're older, you are now taking control of your own health. Who do you allow to listen or get information about your health information, who are you not comfortable with. So we discuss all these things. By the age of 20, we start discussing the logistics of transition. And so for us as the adult children, we allow our patients to choose wherever they want to go to transition to. They just have to let us know who it is, and then we can effectively coordinate. We also work a lot with FACHE for people who want to transition there. And so we discuss all the logistics in terms of, are they able to have transportation to the clinic? What other things can we do to help? Is it too far? Do they need like a wheelchair even when they get to the clinic? All these things we need to coordinate and then discuss with the hospital or the clinic that they're transitioning to. Next slide. So that brings me to the end of this presentation, and I will entertain any questions that people have.
Thank you so much for this presentation, Angela. It was really, really helpful, very, very thorough. I couldn't have hoped for better. We still have a few minutes for questions, so I think maybe I'll start with the one in the chat. John is asking about what have we done to prepare patients to identify and navigate barriers such as racial bias, building relationships, and trust.
So as I said before, for us as Seattle children, it is a work in progress. So when we talk about, we do the assessments and stuff like that, when we talk to the patient, we've not identified where patients tell us this, but now that you mention it, it should be something that we should be addressing, knowing that it's a barrier that prevents patients from accessing the health they need. So yes, we will have to add that in terms of discussing what the patient needs to know before transitioning. Thank you for that.
Yeah, and listening to your talk, I always think about how little actually is done with adult patients after they transition, or even for those who like moved to the area, so they never really had a transition from the pediatric setting to the adult setting. But we are not actively assessing how much patients know about their disease, how much they truly understand about their treatments. So it's interesting to look at all these elements that we're considering for patients undergoing transition, and how actually it could be useful for any patient, really. Since any patient could be struggling. I think the cognitive impairment that you mentioned that some patients go through also can happen later in life to anyone. So yeah, it's interesting to notice that many of the elements that we worry about in transition may not really become, I think they never become irrelevant, even after the transition is successful.
Right, right. And again, and that is why in terms of the adult standard, it mentioned that we should continue to do this. And I'm so happy that us as a team are thinking of how to better do like a transition where patients are adequately prepared and able to function effectively in the new setting they find themselves. So it's good learning for all of us.
And I don't know if you can comment on what your impression is of how different it is to transition patients who are like very sick, like severely sick, and need a lot of medical attention. They get admitted very, very often, as opposed to patients that we also follow, and maybe their disease is not as severe, and if how it changes the process, if you think it's easier or maybe it's more difficult because they're less involved.
Yeah, so I would tell you that since I've been in this position, there's been one that has had a lot of issues in terms of pain, and it's been very, very, very hard transitioning. That is because, one, we think that there is that component of cognitive part of it where they are not probably forgetful, and so we tell them all these things that needs to be done, but they may not even remember to do it. So I think that disease severity negatively impacts successful transition. And I've seen some other kids that didn't have a lot of cognitive deficits, was able to transition effectively. And so looking at the two, I feel like the more severe a patient's condition is, the more challenging transition becomes. And just to say that this person we're trying to transition is still not done yet. And so it's still a lot of work where the patient feels like, I don't want to deal with you anymore. I feel like I'm doing okay. And so they're not even ready to talk to you. But then they're also not going to see the adult provider as they're supposed to. So it is very, very challenging.
And I think finally, can you comment some on what we can do to help parents through this process? Because I think everything we talk about is very patient-centered, but then of course the parents are a big part of this.
Yes. So as the policy says, in terms of when you're even developing the transition policy, it has to have input from the parents, help them. When we do this readiness assessment, where it shows where the patient may have some challenges or where the patient needs more support, I think we have to now tell the parents, how can the parent do this to help? So in terms of, are you able to help your child identify what medicines they're taking instead of you just giving it to them? Are you able to, we teach you what the patient's disease is since they were little? Are you now able to help at home where you tell the patient, this is your disease condition, this is what it does? So even though we are doing it at the hospital or at the clinic, you are the one with the child all the time. So I feel like when we do all these readiness assessments and all, it's now time to bring in the family who are with the kid all the time to help continue the teaching that we are doing, so that the next time you see them and you do an assessment, you should see an improvement and not involve parents and families.
All right. Well, thank you very much again for this very nice presentation and for all these answers to the questions. I think it helps everyone here like understand why transition is so important and so complex, which is why we have so many people involved in this. Well, thank you very much.
No, thank you so much. Thank you. I appreciate it.
I think we're fairly on schedule, and we could move on to the next presentation. I see that we have our next speakers online. I can't thank enough for our next presenters for being here. One is one of our psychologists, Julia Brechbiel, and the other one is one of our psychiatric nurses, Chelsea Hagmann. So Julia and Chelsea, thank you very much for being able to talk to everyone about the mental health aspects of transition and what happens with adults with chronic illnesses such as sickle cell disease. And yeah, please feel free to take it away.
Thank you so much. I really appreciate it. I think we have a shortened, updated version of the slides, if that's okay, because I know our time is a little bit precious, but I'm happy to introduce myself. I am an assistant professor here at the University of Washington in Fred Hutch. My time is 100% clinical. I did most of my training and my rehab here at UW, and most of my time is spent focused on working with people with different health conditions. Would it be helpful if I shared the slides?
That would be great. I don't know if I have the shortened version. Thanks,
Okay.
Julia.
Of course. Chelsea, while I'm doing this, you can introduce yourself if you'd like.
Perfect. Hi, I'm Chelsea. I'm one of the registered nurses on the psycho-oncology team. And my background, real quickly, I am a DNP student at the University of Washington and working towards, I'm in my second year to finish in the psych mental health track. Historically, I was a bedside critical care nurse as well and had the privilege of caring for a lot of patients in sickle cell crisis at the bedside. And so it does provide a bit of a unique experience and perspective in this conversation.
Okay. Continue on, Chelsea.
I can't see.
Oh, no. Okay. So this slide is kind of just a rounding out who else is on the mental health team here at Fred Hutch. Within the sickle cell team, there are two
Julia,
wonderful.
I don't think it's showing to everyone yet.
Yeah,
Oh,
we can't quite see your Julia.
oh, on my end, it's okay. I'll stop sharing and try again. Huh. Normally I'm better at this.
Oh, it's not you. It's usually Zoom.
I feel like you'd think we got better at it. How about now?
Oh, it says you've
Just
started.
choose option to view. Let's look. Okay, and then if you go to view options at the top, everyone, and click Julia Brechbiel, then we can see our slides.
That's
Okay.
correct.
Thank you.
Okay, I'm ready, Julia.
Okay. Now I don't know if I'm doing it right. There we go. Huh.
There you go.
So
Okay,
now
yeah,
we're seeing the wonderful Angela and Savan.
yes. So really quick overview, we have listed our two fabulous social workers assigned to our hematologic disease group, as well as some additional mental health resources. And when I'm speaking today, I'm going to be speaking more so directly to patients and caregivers, just to help provide some context. But yeah, so these attachments of some other resources can be really wonderful for things such as having a mental health crisis and needing immediate outreach when perhaps those don't happen in business hours and you can't call the clinic. So that 988 crisis line is really critical. And then along with just some general resources to help you connect within the community, as a diagnosis like this, along with any diagnosis, can feel very isolating from peers and others. And then NAMI and Therapy Fund can also provide some really fabulous financial resources and housing vouchers if that becomes a barrier to accessing care.
I'd also add that the therapy fund is specifically for people who identify as Black, African American, and they can help you connect with free mental health resources. Same with Angela and Sylvan, that you can just ask your doctor for a referral to social work, and they are non-billable service, so they do not go through your insurance. And then NAMI also has like different peer support groups for people of color.
Yeah, and so one additional thing before I move on to the collab care model is a lot of times patients and caregivers might think of social work in the context of someone that's just navigating resources for them. And our social workers can provide therapy, and that is so critical, especially in our culture right now when it can take such a long time to get in to see someone and establish. You can go ahead and get started with a non-billable service. You're not going to get hit with a copay, and utilize these fabulous social workers. Okay, next slide. Thanks. And then what's really wonderful about starting to work with social work in a concept of therapy or just emotional support is if things become more complex, follow this collaborative care model, and our social workers work directly with our providers, our onc and hematologic providers, as well as our psychologists and psychiatrists. So if you can see, you're kind of in the middle as the patient or caregiver, and then we're really surrounding you with a layer of support. And that can look a lot of different ways. You as the patient or the caregiver can reach out directly and ask for the support. And we're going to talk about some tools to help empower you to do that. Or you can reach out to social work and directly, and they can reach out to the provider through psychiatry or psychology for support. So we really try to lower the barrier to getting additional resource from a psychiatry mental health standpoint.
And so, as you all were talking about transitions before we jumped on, it's thinking about transitions also from a mental health and developmental perspective, that this is probably one of the times in life when you're going through the most milestones and transitions. And that's on top of having sickle cell. You're already making a lot of decisions about education, vocation. There's so many different interpersonal changes. This picture in the corner kind of shows the different layers of influence that can be on anybody, but it's especially apparent in your 20s, 30s when you are growing into yourself and trying to explore different options and figure out your identity and what you want to be doing. And so there's these wider layers of influence being social network, family, and you can see that there's the ring that lists clinic and hospitals actually further out. There's very many layers of influence within your immediate level, both that could be helpful or stressful, as you're trying to figure out what your goals and aspirations are, your identity, your autonomy, what kind of decisions you want to make in life, or even your style and preference of how you want to voice your decision and choices. But we're still there in our layer of influence on how you grow into yourself. And we hope that will be helpful to that transition and not always just a stressor during this phase of life. And so one of those ways to interact with us is really finding your voice and how you want to talk with your medical team. That I think it's important to kind of, each of us has our own threshold of identifying what symptoms and what concerns are tolerable and what are not tolerable. What may work for one patient is not going to always work for another patient. And so often thinking of goals of care, what's important to you is going to be at an interpersonal level and maybe even different than your caregiver. And so that's part of growing into finding your own way of navigating your care and figuring out, is it avoiding hospitalizations and EVDs? Is it having time away from thinking about sickle cell? Is it thinking about being physically comfortable? Is it about having agency, autonomy, and choice, and how you decide what kind of medications and treatments you want? And it's okay to really talk to your providers directly and ask them really blunt questions and ask them to translate out of this medical speak that we sometimes use. And I think most of the providers I've known, nearly all, really appreciate it when their patients just ask them bluntly what's on their mind, because even though we're working psychology, I often joke that we're not psychic. I don't always know what's on my patient's mind. And so feel free to really ask what's important to you. And while, oh, go ahead. Sorry, Chelsea.
I just was going to say another really important part of finding a way to speak to your medical team is really understanding that your emotions are very valid and normal. And I think we live in a culture that really tries to push away an emotional experience, and that becomes very difficult as a human. And so if we can validate for ourselves and our loved ones, if you're a caregiver and your loved one is experiencing this diagnosis, a range of emotions are going to naturally occur. And it is very normal to feel one of these, all of them, none of them, and things that conflict. And that can be very hard for us internally when we're experiencing emotions that perhaps we don't want to be experiencing. And so I think the most we can do as a patient or as a caregiver is to really normalize our emotional experience.
Yeah, and I think there are different accepted emotions that are easier sometimes to express, or some that are taboo based on identity, that there are different racial cultural tropes around and stigmas around anger and or even sadness, or men expressing sadness. And so finding people that you can be really authentic with to share these emotions, or sometimes it's just with your provider where you feel safe. And so part of that is learning for yourself. How do you cope with emotions? And so the next few slides are kind of thinking about, how do you want to be coping with your mental health? What are different strategies you could use? And if you, and these slides are really, I think, designed to think about how you could do it on your own. But you could also do any of this with the help of, say, one of our social workers, a community mental health provider, or with psychology, psychiatry at Fred Hutch. But they're also generally things I think people can work on their own, or with their peer or family or caregiver support system. And so I often think of this metaphor of when I'm at the dentist, how involved do I want to be in my dental care? Am I someone who wants to talk with my dentist and hygienist every step of the way and know what's going on? Or, and like holding my own suction, being involved in my care? Or am I someone who wants to have their headphones on, eyes closed, listening to a podcast or ocean sounds, really trying to avoid and distract myself? I'm more of the latter. I don't like to be paying attention at the doctor's office, and that's okay. There's no wrong or right way to cope. It's just knowing what works best for you, and that's within your kind of area of control or locus of control. There's so many things you. One thing I always remind myself and others is that we can always control how we cope and how we interact with others. And so sometimes people like to be problem focused, solution focused of how do we fix things. And other times there is no good fix for things, and we just have to focus on coping with the emotional side of it. Another way to think about our coping is how can we build our own resilience? And this really comes from an idea of stress inoculation. How have you faced past challenges in life? What has worked for you and what hasn't worked? And learning from those experiences and building kind of a toolbox of how you cope. And this can be made up of social support, spirituality, faith, meaning in life. It doesn't necessarily have to be religious. We talked a little bit about locus of control, or another way to think about it is self-efficacy, building confidence in your belief that you can handle challenges. Or another one we'll talk a little bit more about is cognitive appraisal of how do we think about when challenges arise or ourselves.
I think one other little quick point is like a very short and sweet way that I tell myself when I'm in a challenge is this is hard and I can do hard things. And taking on that in the term of like locus of control and self-efficacy and practicing that narrative can become quite powerful, because you're not saying that this isn't hard and why can't I do this? You can quite literally say, this is hard, this is terrible, and I can do hard things.
Yeah, that bravery isn't the lack of emotions, but more how do we keep going when we are scared?
Yeah.
Okay, keep going, Chelsea. I think this time's you.
This next slide here is piggybacking off of then how do I get that strength to continue to be resilient as things become more and more difficult? And places that we see that can really sort of fill up our cup is that what brings you joy? What in this life, what in your experiences fill up your cup? And I think when people explore what brings them meaning and happiness, can kind of alter our frame of reference for a contextual situation. And I think we can do this for ourselves, and we can also reach out to our support network. As animals, as humans, we are people that enjoy community. And so being able to find people that are non-judgmental, that can validate our experiences, is going to be really important. And I think going back to some of those resources that we first listed in the first couple of slides, being able to find others with similar experiences, especially in the context of a diagnosis, can be really helpful when otherwise we might feel more isolated.
Yeah, and I don't know if I can emphasize enough of finding people who listen without judgment. I'm not sure if other people have heard the term before of like toxic positivity, but this idea of people who will say, oh, wow, you handle this like I could never, you're such an inspiration, you're so brave, when all you're trying to accomplish is living your life with a chronic illness, of who can help you give space when you do feel sad without minimizing that emotion. Okay, so other things too that are maybe more tangible coping strategies. These are ones that you can try practicing on your own or with a mental health provider. That mindfulness relaxation can really help you stay grounded to the present moment. can both ease like physical and emotional pain. And I think it's something we forget about when we're in big transitions in life. These more tangible coping strategies are sometimes the first thing to drop off because we think they are so brief that they are easy to postpone, but they actually have a huge impact if we take a minute while brushing our teeth and be mindful, or while having a snack, or just on my walk, on my commute to the bus. I try to be more present. And so there's tons of free apps in YouTube for guided relaxation. The two pictured here are my favorite free ones that I use. Self-massage or acupressure. We have handouts through UW and Fred Hutch for this. I'll talk a little bit about integrative medicine that helps with this. Sometimes opposite sensory input when we are stressed or in physical pain, such as ice or a heating pad, can be really comforting and relaxing. The same is with behavioral activation. I often think like Julia at rest stays at rest, and then I feel bad that I did nothing that day. And so just finding a small way to be active and doing something that's enjoyable, such as walking or stretching, not stressing. We want to be stretching, not stressing, is going to be helpful of doing something. Even if we don't feel like it, we might feel better afterwards, even though beforehand we didn't think we would enjoy it. And then finding a creative expression can be really helpful to process thoughts and feelings and worries. We have some art therapy at Fred Hutch, something that our social workers really do incorporate into their work. Or finding creative mediums to communicate within your community be really helpful. And so I kind of hinted at this diagram earlier in our presentation that we understand that there are both many layers of influence on our life that can help us through transitions and coping, but they can also pose barriers to transitions and coping. And so some of the services we have here at Fred Hutch that I love to highlight, that I collaborate with a lot, are patient navigation. They are the type of social worker that actually helps with more tangible needs, be it housing, finance, insurance, transportation. Our social workers are those non-billable providers. And then spiritual health are great compassionate listeners. They are both outpatient and actually inpatient. If you were at the hospital, they're a service you can request. Medicine is an option. They really think of the mind-body connection and integrate with nutrition, movement, acupressure, acupuncture, and then our pain clinic is a big collaborator if you want an extra person helping you manage your pain. I know we have a hand raised. Would it be helpful to hold to the end, or should I keep going? Or answer it now? Is there a preference? I'm happy to answer it now. Oh, yeah.
Sorry, that was accidental.
Oh, okay. Thank you. I would be happy to answer if someone had a question. And so another thing that I do talk about with a lot of my patients is how are they interacting with school and work, and what can we do to help them if they need accommodations, a letter, need to figure out how to talk to a boss or a teacher about their health, and how to negotiate, like, okay, I need a little extra time on a task or an assignment, is something I'm happy to talk with patients about all the time. Other things. I think before I distracted myself, I was going to say, if you wanted to access any of these, this is pretty easy. You just have to ask your doctor and they'll put in a referral, and most of our services are available to see people within a couple of weeks. So the barrier to access within Fred Hutch, I find, is fairly low. Oops. Okay. And then thinking more specifically about what psychotherapy actually would look like with someone like me or social work. And Psychotherapy is often very tailored to the individual, so I'm really giving a broad general overview. It may or may not look like this for you or in the community, but most psychotherapy is really focused on coping with the relationship between our thoughts, our emotions, and our physical symptoms, because they really can feed off of each other and are correlated. And we want to, maybe we can't change or improve someone's physical health, but we can help influence or improve the relationship we have with ourselves internally. And so the two big modalities for psychotherapy that you'll most commonly see are cognitive behavioral therapy and acceptance commitment therapy. And so cognitive behavioral therapy kind of sounds like its name. We're really working on understanding how someone's thinking, like, I can't do this, influences their feeling. You might feel anger or sadness or fear from that. And when we have those emotions, our behaviors are going to, maybe we just don't try, we don't get out of bed, we feel are anxious, depressed. And then those behaviors lead to thoughts of, yeah, I was right, I couldn't do this. And it kind of becomes like this spin cycle of thinking, of anxiety and depression. And so what we're doing in therapy is trying to spin off in a different direction of, okay, maybe I was thinking I can't do this. Maybe I change that thought to, well, I'll at least try and see if I can prove myself right or wrong. And then maybe the emotion isn't like we're ecstatic and joyful, but maybe we're a little bit more content with ourselves, so that we have a little bit more self-efficacy or belief in ourselves of, see, I did try something, and that can feel a little bit better than being depressed or anxious. And then we're maybe acting in a different way behaviorally. We're going for that walk, we're doing that stretching, we're making that phone call, we're asking our doctor for help or support. And so just that little nudge in our thinking can create a different pattern of emotions and behaviors. Acceptance commitment therapy is similar, but a little bit more involved. They split up thoughts, feelings, behaviors into a little bit more nuanced domains, where we're thinking about what are our values, what should be influencing our thoughts and our feelings. And so those values of maybe self-efficacy, autonomy, wanting to maybe have a goal in life of wanting to go to college or get a specific job, of making sure our thoughts and our actions are consistent with that value, and finding ways to then notice, who am I despite sickle cell or pain or another stressor, that who we are as a person is different than the things that happen to us or happen around us, even though those things are really hard. And then there's a couple different strategies involved in acceptance commitment therapy as well. So one is being present, that idea of mindfulness that I talked about earlier. And then they think about thinking a little bit differently, that we're not always changing our thinking, but we're noticing it and maybe taking a step back from it. We call it diffusion. Instead of being fused and stuck to it, we want to take a step back and imagine it as passing us by, and we get to choose whether or not it has influence on us. And then if you're interested in either of those, these are some books that I recommend that I really enjoy myself, that have helped me and patients do this work on our own, and not kind of in a cheesy self-help way. So there's 2 workbooks on here, and then the other 2 are values and meaning in life. All right, and so here's our contact information for psych services and social work, that you're welcome to call us. And if you don't already have a referral in, we can actually do some of that legwork and talk to the doctor and say, hey, we got a call in from so-and-so, they're interested in our service, and we can make sure we get a referral and start seeing you. And then this is my wonderful dog, Loki, who was just one of my joys in life. Thanks. Anything, Chelsea? Okay. I'm happy to have questions, any and all.
Thank you both for this wonderful presentation. And
Yeah, thank you so much for that presentation. It was amazing. Thank you so much. I just wanted to ask, so when you are taking care of a patient who tells you that I don't want to do anything, I don't want to go out, I don't want to do anything fun, because everything I do triggers pain. And this is the person's experience, it's not just a feeling. How do you use behavioral cognitive therapy to help break that cycle when they're actually experiencing it?
Absolutely. And so I think sometimes I have to be really honest with my patients that psychotherapy isn't going to actually address the pain itself, but it's going to maybe be a different relationship with the pain. I often tell my folks, like, if we could, we would break up with your chronic illness. It's not a healthy relationship. Either we need to have a better relationship with that chronic illness, or I wish we could break up, but we can't. And so psychotherapy and these coping strategies can definitely reduce the intensity of pain, but not eliminate it. Or I think of it as the pain's still there, but it's not impacting your day-to-day functioning. And so often I end up collaborating with the medical team to say, hey, so-and-so's pain regimen, their pain is a 10 out of 10. Psychotherapy isn't going to touch 10 out of 10 pain. So let's collaborate to bring the pain down more, where it's a little bit more malleable for psychotherapy. And finding what that tolerable rating number is for a patient. It's going to be really individualized. And so there's some protocols where it is 10 to 12 sessions of psychotherapy where we really change someone's thinking about pain. And most people at the end of it find that they are functioning and having a better quality of life, but their pain is still there, but more in the background of their head. Kind of like, I think of notifications on a phone. We're kind of turning off the notifications for the pain that's just in the background. We don't often.
I think too, a lot of that starts with validation of pain. You know, especially when I was in critical care bedside, that was something we were really fighting with a lot of providers, frankly, and perhaps family members on, was the invalidation of a pain experience. And so I think just even starting baseline with validating that experience and making sure that we're able to get to a space of acceptance of pain versus jumping right into changes.
I was wondering if you could comment on something maybe to me looks kind of basic, but kind of complex, which is just around how to handle like anxiety in the treatment of such patients, especially when we're talking about transition changing provider people.
Yeah, I think anxiety is really real and valid. Again, like to Chelsea's point, validating first that anxiety is, if I had had more time, it would have kept it in my slides. It's normally a response to fear and change, and it's kind of this protective mechanism we have. I think of it back like our reptilian brain or an outdated processing system like Internet Explorer, but we can't get rid of it. We can't uninstall it. It's our body, our brain trying to protect us. And so if you've been working with someone for 20 years and they've kept you safe and taken care of you, it feels irrational to leave them. Like that's a healthy relationship. Why would you leave them? But I think it's also reframing it as it's okay to outgrow people. It's more of a graduation. You are needing someone who has different skill sets, different experience, who can take you further than maybe your past provider can. And you outgrow that system is a okay thing. It doesn't have to be a negative. It's reframing the difference between anxiety and adrenaline and excitement can feel very similar in our body, like a roller coaster. And so it's figuring out what's the fear and is change okay? Is it safe right now? Does that make sense? Is that okay?
Yeah, absolutely.
Yeah, I think like long-term practices, mindfulness is just, I mean,
Mhm.
abundantly supported in literature as an intervention that we all can do to really help adjust our body chemistry when we're experiencing anxiety. And again, that's a muscle that we have to practice over and over again. That takes a great deal of effort and is hard. It is hard. um,
Yeah.
I think there's this concept of like we can change all these things really easy and we can't. It's very hard, but we can do the hard things.
Yeah, I think it's hard for every patient with any disease. I think when with sickle cell disease, it's particularly more challenging because you're dealing with this since a very early age. And that, of course, primes your brain to behave in
Yeah.
a certain way. And I think that's
Mhm.
why it becomes much more challenging. I am so very grateful to be able I can count on a team like yours. I've worked in other settings where resources were very, very limited. I couldn't
Mhm.
even afford a social worker for myself. I had a social worker just for the whole clinic, right? For the whole center. And which creates lots of barriers. Like there's only so much one
Mhm.
person can do. Uh,
Absolutely.
yeah.
Mhm.
And I think it's just to highlight like how important it is that multidisciplinary approach that Angela mentioned in her talk, and now moving forward, how important it is to keep the multidisciplinary approach throughout the transition and further.
Absolutely. Yeah, it's becoming much more commonplace now for there to be these transition clinics for different disease groups. I've seen it for like arthritis, diabetes, and it's really encouraging to see it for sickle cell as well, where people are living so much longer with a condition and needing to transition to adult clinics that can feel much more intimidating or foreign. But it's nice when there are providers and connections across these institutions. And so our social workers know the social workers at Children's, for example. And so I imagine there are going to be ways to do like handoffs and transitions.
Yeah, and for a more practical approach, like
Mhm.
can you comment on, for example, if an assessment by social workers should be part of every transition process? How often? How do you envision this happening ideally?
Yeah, I think the way I've seen it in other clinics is that there is sometimes this introduction, like when you're first coming into a clinic, like if you were new to FACHE, you would get to meet everyone, just have a little FaceTime with everyone on the team. It can feel like a long day, but that way you are really aware of what your resources are. So kind of coming to a talk like this is like an example of it. You got to hear from a lot of different people today, and you continue to. And then maybe when you're ready to finish that transition, you also have like a graduation session just to check in to monitor if you've hit a bunch of milestones, like you feel confident with medications and insurance and navigating systems, and that self-assessment if you're ready to go through a transition.
We also have a form that Epic populates for any new patient
Mhm.
that's supposed to trigger different referrals.
Okay.
I feel that we're still workshopping that algorithm. I think it can be so overwhelming with a new patient, a new diagnosis, or just not a new diagnosis, chronic, but now we're at a new clinic, and you're getting 17 different referrals. And so I'm hoping, I've been a part of some of those conversations, and I'm hoping that we're going to start finding ways to sort of ladder that so that someone isn't hit with so many referrals and resources because we just get fatigued.
Mhm.
That's fair.
Yeah.
Yeah. Mhm.
All right. Any question? I don't see any questions in the chat. But yeah, you guys, all your contact information, and we're happy to connect people
Please.
to you as needed after the event. Again, thank you so much for
Thank you for having us.
here and for taking the time to prepare this material. I think what I'll do in the interest of time and everyone, and I think everyone has been on time so really well, is we'll give everyone like 5 minutes of like a bio break, and that way we can move on to the two final presentations and maybe give people back some time of their Saturday. All right, we're back and continuing our schedule here. I'm going to be talking about sickle cell disease management. For those who join later, my name is Kleber Fertrin. I'm an associate professor at the University of Washington and the director for the sickle cell disease and iron overload program at the Fred Hutch. And these are my conflicts of interest. They don't have anything to do with the content of this talk. So my agenda for this talk is first give a brief overview of the mechanisms involved that cause the symptoms in sickle cell disease. I'm just hoping that with that, it's easier for people to understand why we use the medications we use, with the intent to reduce pain crisis and also to improve anemia in sickle cell disease. And finally, I'll talk about cell therapies for sickle cell disease, and those include both bone marrow transplant and gene therapy. So what happens in a person with sickle cell disease, and this is going to be a little different from what I would usually show to like fellows, residents, because I want to just focus on a more practical way of looking at what these treatments are doing. But as we know, sickle cell disease is caused by a genetic mutation that causes the bone marrow to make, instead of making hemoglobin A inside the red cells, which is the adult hemoglobin, normal one, it makes hemoglobin S, which stands for the sickle hemoglobin. And as we know, sickle hemoglobin under certain circumstances, such as low oxygen, infections, exposure to cold, it can polymerize inside the red cells, cause these polymers inside the red cells cause red cell damage, which usually we think about as sickling, but in general, it doesn't have to make the cell in a sickle shape for the red cell to be damaged. It will still cause the cells to be abnormal. Those red cells, by having this damage on their membrane, they will last for less time. So it causes anemia with red cell destruction, and it causes vaso-occlusion because these damaged red cells also stick to the vessels. They cause pain. The way we like to think about sickle cell disease, it used to be something like this. I'm representing the endothelial cells that line our vessels, our capillaries. And then you have to think about this as it could be the smallest vessel in the body. And the cells sickle for several reasons. They release these molecules of hemoglobin in circulation. That this hemoglobin is also like irritating to the endothelial cells and to other blood cells. They cause what we call oxidative stress, so it damages membranes of the cells. And then we think about sickle cell disease at first as all these sickle cells piling up and blocking the blood flow to the vessels. But since at least the early 20,000s, we understood that the red cells are not the only ones involved in occluding the vessels. We have, on top of this nitric oxide depletion caused by the free hemoglobin, we have other cells, other blood cells involved in vaso-occlusion. So the white cells, which are much, much bigger, can also stick to the vessel and cause occlusion. And the platelets also express a protein called P-selectin, which I'm representing as a letter P, and they help the cells stick together. So it's not, even though it starts with the red cells, it's not only about the red cells. White cells and platelets also are very important for the process that causes pain. And then eventually it amplifies, so you get more platelets sticking, more red cells sticking, more white cells sticking. Sickle cell disease is systemic and progressive. We don't have time to go over all the complications that patients can face with sickle cell disease, but it's just to show that since it's in the blood and it's occluding the smallest vessels in our body, and virtually any organ can be affected by sickle cell disease, which is why we want to develop better treatment. The vaso-occlusive crisis, also known as pain crisis or vaso-occlusive event, is the most important manifestation of sickle cell disease, if I can say. These are acute episodes of musculoskeletal pain, and there's a variety of triggers: infection, trauma, surgery, menstrual periods. These are all very well known, as well as dehydration, exertion, cold exposure, even emotional distress. But 50% of the time, we really can't tell what triggered the crisis. And the frequency varies a lot. Some patients might have a crisis yearly, as opposed to patients who might have it daily. So this is also like an area of intense study, trying to figure out why certain patients have more frequent pain crisis than others. A specific type of vaso-occlusive crisis is acute chest syndrome that I have to mention before I talk about management, because it's the leading cause of death and the second cause of admission in adults with sickle cell disease. Typically, patients will have fever, some respiratory symptoms, just as chest pain or shortness of breath. We'll pick up some abnormality in the X-ray or CT of the chest. They may or may not require oxygen. And common triggers are obviously pneumonia, infections, but also just prolonged vaso-occlusive crisis. If left untreated for too long, it can lead to what we call bone marrow fat embolism, and that also affects the lungs and leads to sickling in the lungs. Typically, we'll manage acute chest syndrome as any other pain crisis, so aggressive pain management with opioids and anti-inflammatory medications is important, fluids, checking for the triggers that we can treat, infection, dehydration, an asthma attack. But also, we'll typically add antibiotics and give patient oxygen depending on how severely ill they are. And we'll also consider red cell transfusions for severe cases of acute chest syndrome. Finally, if you lots of pain crisis or acute chest syndrome, we should consider starting a sickle cell disease modifying medication or changing the therapy if the patient is already taking something. And if the patient is already taking, for example, hydroxyurea, they should never stop the therapies during the admission unless they're unable to take it for other reasons. I mentioned transfusion, so I'll start there. Transfusion is probably the oldest treatment that was ever offered, specifically like trying to improve sickle cell disease management. And I just note that we need to try to use phenotype blood to avoid antibody formation, because patients with sickle cell disease might need transfusions through life. Typical indications are acute chest or liver and spleen complications, also patients whose hemoglobin drops and they have symptoms. And finally, we can also do that prophylactically prior to surgery, for example. Transfusions in sickle cell disease will essentially only dilute the sickle cells. So I want to represent this in this chart just by showing like how it would look like. So it's not that you're not removing or unsickling red cells, you're just diluting the sickle red cells and also allowing the patient to transport more oxygen, which is always beneficial. This is a cartoon I'm going to use several times in this presentation. So this is how I would represent a transfusion. You have a mix of red cells that contain a lot of sickle hemoglobin and the red cells from the donor that are in red that don't have sickle hemoglobin. And then under stress, low oxygen, etc., you will have the sickle red cells from the patient still sickle while the donor cells won't sickle. There's a different approach to transfusion called red cell exchange that many of you must be aware of, and we use that to remove the patient's sickle hemoglobin containing red cells to replace them with donor cells. It's usually done automatically with the machine. It's more efficient, but it can be done manually exceptionally. Most of the time, we use red cell exchanges for patients with brain complications, so abnormal TCD, stroke, sometimes acute chest syndrome or liver complications, and obviously very severe cases of multi-organ failure. Red cell exchanges will also dilute the sickle red cells, but will also remove some, so you get a better mix of normal red cells and sickling red cells. So it's better than simple transfusion in most cases. And then, since transfusion clearly doesn't fix sickle cell disease, there has been a lot of effort trying to develop medications that can improve sickle cell disease. I'm going to briefly talk about the 4 medications we have approved right now. Hydroxyurea approved in 1998, L-glutamine approved in 2017, and then Celator approved in 2019. So for hydroxyurea, it does a lot of things, and that's the reason why you will appreciate why it's become the standard of care for sickle cell disease. Hydroxyurea will increase the production of red cells that are rich in fetal hemoglobin that I'm representing in green. So fetal hemoglobin is a hemoglobin that we make as before we're born as fetuses. And it has an interesting property that it doesn't allow the sickle hemoglobin to polymerize. So the higher your level of fetal hemoglobin in a red cell, the less chance that it will have polymers of hemoglobin as and have damage. So I'm representing a spectrum of red cells there. Some of them are very, very green, so have a lot of fetal hemoglobin, but you can have all sorts of different levels of fetal hemoglobin. And that will affect how much benefit the patient gets from hydroxyurea. That's only one of the effects of hydroxyurea. Hydroxyurea can also donate some nitric oxide that helps relax the vessels, that nitric oxide that they lost with the hemoglobin that's being released from the red cells that get damaged. And finally, it can also decrease the amount of white cells and platelets. So it also has a good effect on decreasing vasocclusion and therefore pain crisis. Who should be considering taking hydroxyurea? Any child over 6 months of age that has had like severe crisis like dactylitis or several pain episodes, acute chest should be considered for that. Virtually any patient with sickle cell anemia or sickle beta 0 thalassemia above age 9 months, and all symptomatic adults, regardless of sickle cell disease gene subtype, should be considered for hydroxyurea therapy. In my cartoon, the way I like to think about it is that when you give someone hydroxyurea, the bone marrow will start making a combination, a range of sickle cells that contain some more fetal hemoglobin than at baseline. And then when exposed to those harsh conditions, some of the cells will still sickle, even if they have some fetal hemoglobin, but the cells that have higher levels of fetal hemoglobin won't sickle. And that's kind of the limitation of hydroxyurea. You can't really tell who is going to have a good response. You also can't tell how high of an expression of fetal hemoglobin certain cells will have. So it's always going to be a combination of cells that improve and cells that don't improve with this therapy. Then moving on to L-glutamine, this was approved in 2017. I'm just highlighting there that the study tested L-glutamine in patients with sickle cell anemia, beta thalassemia, and beta plus thalassemia, but not SC disease, and that 2/3 of patients were on hydroxyurea. So it's a therapy that can be used on top of hydroxyurea. What L-glutamine does is mainly reduce the oxidative stress, so decrease the amount of damage the red cells take, and also reduce the activation of the blood cells in general, which is why we think it decreases vaso-occlusion. As you can see, it doesn't do anything to the hemoglobin, so L-glutamine will not improve anemia. Crizanlizumab is the other medication that we use to reduce pain crisis. Again, similarly to L-glutamine, it was tested in patients with 2/3 of the patients were on hydroxyurea in the trials that led to its approval, but it's been tested in other genotypes other than just SS disease. And what it does, it is an antibody against that P-selectin that I'm representing as the letter P in the cartoon. So what happens is you'll have less adhesion of white cells and platelets. So it's definitely meant to decrease vaso-occlusion. It decreases the frequency of pain crisis. It also will not affect hemoglobin levels, so anemia will not improve with this medication. And finally, voxelotor is the 4th medication that we can use for sickle cell disease. Again, about 2/3 of patients in the trials were also on hydroxyurea, so it can be combined. And 88.9% of patients had some improvement in anemia levels with this medication. So what it does, it binds to hemoglobin S inside the red cells, and then these cells are less likely to sickle under low oxygen and so on. So it improves anemia in about 90% of patients, but unfortunately, even though it's an anti-sickling drug, it hasn't translated into a huge improvement in pain crisis. So for patients who need transfusions or have severe symptoms of anemia, it might be a good option to consider because virtually anyone can respond to that. But it's not the best medication alone to be used to reduce pain crisis. This is a brief summary of the medications that we use, and I like to go back to this table when I'm trying to think about whether I want to improve anemia, whether the patient needs to improve pain crisis, or both. So that helps me combine or choose what's the next best option. Of course, if the patient has a preference between oral or infusion, that also plays a big role. And finally, the side effects. They're very common across all the medications: headaches, nausea, vomiting, sometimes rash, sometimes joint pain. So we have to figure out like what the patient can tolerate and what the patient cannot. Also, like the combination between the medications, it's possible to combine all of them. There are some challenges trying to get approval from insurance for several medications at once, but on occasion we are successful trying to combine all these medications. So as it might be obvious at this point, even though we have several medications to treat sickle cell disease, perfect, they kind of improve the frequency of pain crisis or anemia. The improvement is not uniform across patients, so we're always looking at therapies that can actually cure or at least transform dramatically the way that this disease behaves. And allogeneic transplant is certainly the first and the most studied type of therapy that can really change sickle cell disease. It was first used in 1984. Overall, about 3,000 patients with sickle cell disease have undergone hematopoietic cell transplant worldwide. And unfortunately, only 17% of sickle cell disease patients will have a MASH-related donor, which is like the ideal donor for someone to get a transplant. So that means over 80% of patients won't have that as an option. The criteria for a transplant are quite broad. The NIH recommends transplant for any patient a year, which is pretty common. But also, of course, for patients who have had any severe complications, stroke, acute chest, despite being on hydroxyurea, sickle cell kidney or liver disease, pulmonary hypertension when the blood pressure to the lungs is increased. So any more definitive complication will be grounds to think about the possibility of transplant for a patient. This is just to showcase one of the largest surveys looking at 1,000 patients who got transplanted for sickle cell disease. And the overall survival is quite high, especially in the pediatric population. So 95% of patients survive 5 years after the transplant. 81% of patients above age 16, which might look concerning, and of course it is, and that's why we don't indicate transplant easily. I think we have to consider how severe the disease is, because we know that if you have a severe complication, there is a risk of death. And the other problem that we have with transplant is the chronic graft versus host disease. It's a reaction of the new bone marrow against your own body. And unfortunately, it can affect between 13 to 20% of patients. It behaves like an autoimmune disease that you acquire after the transplant. So again, these are the complications that we worry about when we're considering someone for transplant. But overall, these results are better than many transplants we do for other diseases like leukemia. There has been a lot of work trying to find more donors for patients. So one strategy that would increase a lot the ability to find donors would be what we call haploidentical bone marrow transplant, which means you're using a donor that's only 50% a match, and almost every patient, or at least many patients, have at least a parent or a sibling who is half compatible. And again, in this study that was presented last year, they had very good success using this kind of donor for transplant, they had again a 95% overall survival after this treatment. And differently from earlier attempts of using transplant for sickle cell disease, their rate of graft failure, which is like when the new marrow doesn't engraft, or death, or severe graft versus host disease, was fairly low. Like all of the numbers we're looking at on this table are under 10% or under 5%, which is really a very low incidence of these complications. But again, it's not 0% of those, 0% deaths, we always see some patients can get very complicated transplants. And that's the reason why there has been so much investment in trying to develop what we call generically gene therapy is actually an autologous transplant with genetically modified stem cells. So essentially, instead of looking for someone who is a match, you get the patient's own stem cells and make them healthy so they can get transplanted back to the patient. And the advantage is first, those 83% of patients who don't have a sibling that is a match for a transplant now can become their own donor. And also, there is no risk of rejection or of graft versus host disease because it's your own cells, so there's no reason to reject or the new cells to reject your own body. There are two different gene therapies that have been approved by the FDA in December. The first one I'm going to talk about has this very, very long name, and I'm going to talk, I'll refer to it as lovo-cel, which is the shortened version of the name. And lovo-cel is essentially a gene therapy that is based in getting the stem cells from the patient and using a lentivirus, which is like a long-term virus that can carry pieces of DNA into the cell. So that lentivirus includes a new copy of a normal hemoglobin gene inside the stem cells. So in this case, it's a copy of the HBB gene, the gene that's mutated in sickle cell, but it's a version that contains a new change in amino acids that has an anti-sickling property. So on top of being like a normal hemoglobin, it also would prevent any sickling. After you get the stem cells, you modify them in the lab, then the patient needs to get chemotherapy so you can like open space for the new stem cells, the modified stem cells to grow. So it works like a transplant. The patient still needs chemotherapy and then receives their own stem cells after the modification, so they can make the normal hemoglobin. This is a graph showing like in orange, you can see how much of the hemoglobin is like sickle cell or any other hemoglobin that the patient makes on their own. And then in purplish, it's the amount of what we call the transgene or the gene that was added. And you can see that it's about 50% of expression of the normal hemoglobin. And 87% of patients achieved at least 30% of this new hemoglobin production, and 100% of them had a durable response over 1.5 years. The primary endpoint, which is like the goal of the therapy, is to get patients to be pain-free. So that's what they're tracking with these red dots in this graph. And before the 0, you can see that patients had a lot of pain crisis during the 2 years before the treatment. And then you're following with the red dots if the patient will still have any episodes of pain. It's not perfect. You can easily see that a few patients still have pain every now and then, but most of the patients, to be exact, 88% of the patients stopped having pain crisis during the period of observation of the study. And this study is still ongoing. I think we'll learn more about what happens in the long run. But even the patients who had occasional episodes of pain, the median of a frequency of vaso-occlusive crisis was still much lower than their baseline. If we look at the numbers, most patients had an average of 3.5 crises per year. and then the median post-treatment is 0, but some patients would have up to 3.6, but in comparison to having like 16 crises a year. So even the patients who didn't become 100% crisis-free, the decrease was pretty significant. This is my representation of how low cell gene therapy works, right? So you move from having a bone marrow that makes 100% of cells that have sickle hemoglobin, and then if you do have a successful stem cell mobilization, modify them in the lab, get the chemotherapy and receive low cell, your marrow starts to make red cells that have 50% of normal hemoglobin. So essentially recreating what would be probably like a sickle cell trait kind of situation. There's a boxed warning that I need to highlight for lovo-cel because they've had a couple of patients develop some sort of hematologic malignancy, and they recommend monitoring the patients closely. We know for a fact that patients with sickle cell disease have a slightly higher risk of developing bone marrow disorders such as leukemia. The incidence is still pretty low, but it does happen, and there are studies looking at that. So it's hard to say if these patients would have developed leukemia regardless of the treatment they received. But it is a fact that these patients did have that after the transplant. And while having leukemia after a transplant is a risk for any transplant, it's something that is concerning, and we need to monitor patients for many years after having gene therapy. The other gene therapy that was approved is called exa-cel. And exa-cel is different from lovo-cel in just the way that the genetic modification happens. So instead of introducing a new gene that makes normal hemoglobin, for exa-cel, they use CRISPR editing, this new technology that allows us to edit the DNA, and it changes an enhancer that controls how much fetal hemoglobin a person can make. With that, you can make the marrow produce very high levels of fetal hemoglobin. And as we saw with hydroxyurea, if you manage to get a lot of fetal hemoglobin in your red cells, then there will be no sickling and there will be no problems with sickle cell disease. So that was the idea behind this medication. They use a similar plot to track the pain crisis. In this case, these are the blue dots or diamonds that you can see. And again, before time 0 are the pain crisis the patients have had 2 years before they got the treatment, and then they're tracking the vaso-occlusive crisis after the treatment. Similarly, it's not perfect. You can see that a few patients still had some pain crisis, but overall they had 97 patients remain free of vaso-occlusive crisis for 12 consecutive months. And looking at the fetal hemoglobin and total hemoglobin, they were able to induce very high levels of fetal hemoglobin, around 36 to 40%, which is much higher than we get with hydroxyurea. The best responses with hydroxyurea will get to maybe 20% of fetal hemoglobin. And most patients will have an increase of about 9–10% when they have a good response in clinic. So this kind of therapy definitely takes the fetal hemoglobin induction to a new level. In terms of safety, similarly, most patients will have complications of the chemotherapy while they're in the hospital. They have not reported any serious adverse events. They had one patient die during the study, but it was attributed to respiratory failure due to COVID-19. So it is pretty important for patients to avoid catching any infections when they're recovering from this kind of therapy. And they did not have any cases of bone marrow cancer with this treatment. Similarly to the other cartoon for exa-cel, it requires the same steps. You still need to mobilize the stem cells, get chemotherapy, and then receive the modified stem cells. But then the aftermath is that your marrow is able to make red cells with very high levels of fetal hemoglobin, and they won't sickle. This is more like a summary, getting to the end of my talk. So just a reminder that we do have lots of options to treat sickle cell disease with cell therapy or without cell therapy. Nothing is really is perfect at this point, but there's also like a whole lot of other medications that are being studied, trying to improve the management of sickle cell disease. And also we can anticipate new versions, better versions of gene therapy coming down the pipeline as well. And with that, I'll end my talk, and I think we still have a few minutes for questions. Let's see. I don't see any questions in the chat. Any questions for our panelists? Well, if we don't have any questions, I think we can move on to our last talk of the day. I'm really happy to have Dr. Martin Makela here to talk about the ED experience of patients with sickle cell disease. Martin, if you can share your screen whenever.
Initially, I wasn't going to have a PowerPoint, but I thought I'd bring up some talking points, so we could do that.
No problem.
Do you see the presentation?
Yes, looks good.
Okay, good. I just want to make sure that 4 years after COVID, I can still make it happen on the first try. Often not. All right. Well, thank you for inviting me. I'm happy to be part of the transition. This is something we've worked on for many years, trying to make the transition into adulthood and into adult medicine a smoother experience. And we've had fits and starts, several things along the way, but we all want to make this smoother and easier for people. So I am happy to be here. I am an emergency physician by trade. I've been at the University of Washington Emergency Department now for about 15 years. I was the medical director for 10 of those years. And although I'm not the medical director now, I'm still heavily involved in the emergency department and retain my interest and hope for sickle cell patients. So what I'd like to do is talk a little bit about really what an adult emergency department experience would be. I'm going to throw out some dirty laundry and say the things that we can't do because we can't do a lot of miracles, but I do want to just kind of echo on what's been said before earlier today about being your own advocate. This is a big change in going from being a child to being an adult. And this is one of those events that may feel very lonely the first time you have to go through it alone. So I just wanted to start really by talking about what happens in our emergency department. So I put up a couple of notes there just to mention that the University of Washington Emergency Department is the emergency department for Fred Hutch and for sickle cell patients associated with Fred Hutch. And I say that because we have special training at that institution. This is where we want to admit people if they need to be admitted. We have close connection. If you go to another emergency department, there is not that close connection. I would hope that the care is good at any emergency department, but it is not the connection. It is not the communication that we have with Fred Hutchinson. So I just wanted to mention that because we do want to have you there. We are the best place to take care of anyone with sickle cell disease. But it's also a place where we take care of several other very serious diseases. Strokes, heart attacks, the cancer care that we give through Fred Hutch. We are also the emergency department for those people from Fred Hutchinson. And we do lots of organ transplants in our hospital. So it's a very busy hospital, and we take care of very, very sick people. In the national scale of hospitals across the country, we take care of the sickest patients at the University of Washington Hospital. So it is a very busy place. It is a very complicated place, and it will feel different than your experience at Children's. I can promise you, for better or for worse, there is not a teddy bear on any wall in our emergency department. It is not a child-based emergency department. And for many people, That's a big, big change. It will not feel that you are loved the way that you are at Children's. And I say that very carefully because it's hard. It's hard to come in and not feel that environment that you've had at Children's before, that feeling that you get at Children's. You are now an adult and you are being cared for with other adults who are dying. So it's a complicated place, and I just wanted to start with that. Many of our patients arrive by ambulance. There's lots of activity, much like you see on television. Although it's romanticized on television, we have all of those things that happen in our emergency department. Something that we do in all emergency departments that happens at Children's too, and you may not have seen it, and that is the patients are triaged by level of severity. And severity means, am I going to die right now? Am I going to die in a few hours? Am I not going to die? We look at that and what we need to do in the emergency department to keep people from dying. And sickle cell disease is certainly can be a fatal disease. And so when you come in the door, we are concerned about the complications of sickle cell disease and what's going on there. Usually when sickle cell patients come to the emergency department, it's because of pain. And we use that pain as a measure of what is the serious disease going on. It's not just a vaso-occlusive pain crisis. What is that vaso-occlusion causing? What damage to the organs is it causing? So we want to see you just as quickly as possible, but there are other patients who are also very sick. And so that's the challenge in the emergency department. So I just wanted to kind of walk through a trip to an emergency department if you haven't thought about it as an adult or really as an individual person. Hopefully you have been supported by parents along the way, and you haven't been alone, but someday you will come into an emergency department on your own. And so I just wanted to present some of the things that happen in an emergency department. When you come into the emergency department, the waiting room will probably be full and there will be other sick people. They will look bad. They will look sick. They will smell bad. They are adults and they have adult problems. We see all of the things in the emergency department that society has trouble with. So we see people with various levels of drug addiction. We see the homeless population. We see the psychiatric population. So just walking in the door is going to be an eye-opening experience. We do need to get you registered. This seems impersonal and it seems you're in pain, but we have to get you into our system so that we can order medication, so we can get the records, so we can do the tests and be safe. So while it seems like an inconvenience, we do need to get you registered in our system. And then we get you to a triage nurse as quickly as possible. The triage nurse is the nurse who will take your vital signs and decide how sick you are, find out what you need from us. Sometimes we're able to give pain medications right in the triage bay before you've even seen the physician. But you see a triage nurse, and that helps us to kind of understand where you fit in our group of other sick patients as well. We know that you're in pain, but we have other patients who are also in pain and who are sick, and so we have to figure that out. None of us would love anything more than to be able to take you straight back. When the emergency department is not busy, when there aren't other patients there, we will bring you back to a room and start your care as quickly as possible. We wouldn't need to triage. But often we triage and often you will have to wait in our waiting. Sometimes we can start care there. Sometimes we'll even start an IV there to get pain medicine started. But often we have a wait. This is partly because of COVID. We're still recovering from that. It's partly because there are so many patients coming to emergency departments. But it is very difficult for us to be able to get someone straight through without waiting. But we will get you into a treatment room as quickly as possible, where you will be seen by another nurse. We will usually, for someone in a vaso-occlusive crisis or a pain crisis, we will start an IV immediately. We will start fluids immediately. We will start medications as quickly as possible, and we will get blood work going. We will offer you warm blankets. We will offer you warm fluids because we think that the warmth helps decrease sickling and may help with your pain. I know it seems like giving a warm blanket in an emergency department that I'm describing seems like a silly thing, but we know that warmth seems to help pain crises. So we always offer the warm blankets. And then you will be seen by a doctor, usually a resident physician here at University of Washington. They will talk to you about what you need, what's going on. We review your records, we talk about your treatment plan, and then we will start that treatment plan. The severe, significant advantage of being associated with Fred Hutchinson and the University of Washington is that almost every patient has a pain plan, so that when you come to our emergency department, you don't have to convince the doctor of what's going on. We look at your plan and we give you the medications that have been predetermined. We want to make this efficient. We want for you not to be begging for medication. We don't want there to be a delay. So by having it done ahead of time, things happen faster, and there's less argument about what's going on. We also, as I mentioned, are always concerned about what's the source and what damage is being done. The pain is the symptom, but what else is happening? What do we need to look for? Are there other signs of infection? Are there other problems that we have to evaluate? Many of the care plans go on for several hours, giving medications every hour or so. And so you'll be continue to be reevaluated during your care in the room. But again, as an adult, you may be in the room alone. The nurse is not going to be in there the whole time. You may not have a parent with you the whole time. We do have television, but you will still be alone, and it may be very, very scary to be there alone. If the pain plan is successful and your pain's under control, we will send you home. But if you've had narcotic medications, we have to make sure that you can get home safely. And again, if you're here alone and your parents are not able to drive you home, we have to find a way to make that safe. That becomes a big issue for us sometimes, especially if you've been in the emergency department for several hours and now you're frustrated, but your pain's a little better and all you want to do is get home to your own bed. And we have to find a safe way for you to do that, because driving your own car on narcotic pain medications wouldn't be a good idea. So here's some of the dirty laundry I wanted to talk about. I've mentioned this already, but there are other sick patients, and I can promise you, you will not be seen as quickly as any of us would like. I would like nothing more than for you to walk in the door, walk straight to a treatment bed, and for me to get medication into you to feel better immediately. But that's just not possible. On a good day, meaning there are no other patients, it can be faster, but some days you will have to wait. And that's a challenge that makes everyone frustrated. We all know that sickle cell is a very, very complicated disease. The care plans, as I mentioned, are a good place to start. Make sure you know what your care plan is so that you can be your own advocate. Everyone today has said you need to be your own advocate, and that's part of knowing your care plan is part of your advocacy. As I mentioned before, you may be in a room for a long time, an hour or two or three or five or eight, and there's not going to be someone at the bedside with you that entire time. There's a call system, you can get up and move around, but for some people in the transition from children's, it feels like no one cares about me. I'm just sitting in this room waiting, and that's because we need time for the medication to take effect. Sometimes you're there through a shift change, and that can seem confusing because you've had a nurse with you or a doctor with you for several hours, and now there's a new person coming in who is feeling fresh and just had coffee and they're perky, and now you have to tell your story again. And that can be frustrating also. It seems like none of us talk to each other. We don't know what's going on. But really, it's just that we can't be there 24 hours a day and there's a change of shift. So often this is something that's new to people that they don't really realize that we're not in the hospital the whole time. I want to promise you from the emergency department, everyone there is specially trained. I do that training. Kleber does that training. Our people know sickle cell disease better than anyone else in the state. Everyone there wants you to feel better. Everyone there is there to care for you. This is the place for you to be seen. However, you may be elsewhere. You may be in Aberdeen. You may be in Omak. You may be in Spokane. Not all emergency departments are comfortable or have much knowledge about sickle cell disease. And so I would ask that you understand that in a small rural emergency department that you might end up in because you're traveling somewhere, they may know almost nothing about this disease. They won't have access to our care plans. They certainly won't feel comfortable with the levels of narcotic medications that we need to use sometimes. And it will be a struggle. Talk to anyone who's been to a hospital outside of ours, and they will tell you it's very difficult to get adequate pain control for a sickle cell patient. We are trying to national level, but it's very hard. If you are in an emergency department and you're advocating for yourself and it doesn't seem like you're making progress, ask them to call us at University of Washington. We can speak physician to physician and talk about what the care has been when you've been to see us, what your care plan is. Yes, these are safe doses of medication. Yes, we have follow-up. All of those things that scare emergency physicians, we can talk about to them specifically. So if you're somewhere and you're feeling that this is not going anywhere, please have them try to get a hold of us, and we will try to help you out. With that, I'd like to open it up for questions. I know the emergency department is not where anybody wants to be. It's an ironic piece of medicine that I'm the doctor that no one ever wants to see. But it is part of your disease. And I'm sad to say that, but whether you're there once a year or once a month, the emergency department has a very important role in your care. And so we want to make sure that things are as good as possible for you. So if anyone has questions, I'd be happy to talk about them.
Thanks, Martin, for that presentation. It's I think it's always useful to have this like very pragmatic approach to how patients get seen in the emergency department, because I couldn't agree more. Like, of course, we would like we would like for the emergency to be empty and ready to take any patient at the moment that they have pain, right? And also to that point, we've been trying to provide patients with pain medication in the clinic when it's like what we call an uncomplicated pain crisis, because we understand that it both like helps patients get better faster and also sort of triages the more severe patients to be seen by the emergency. So if we see that someone is really not doing well, high risk of acute chest, then we really want them to be the priority to be seen at the emergency. I see some comments and questions in the chat. Foxy's asking about who is the staff and roles in the ER, and if the pain protocols are in Epic, and if so, where do they live?
They are in Epic, absolutely, but not every hospital uses Epic. Epic would hope that we all do, but there are many hospitals, especially the smaller hospitals, that do not use Epic, and so they would not have access to that. So that's a great question. The staff names and roles, there's a triage nurse, and Foxy, I'm not quite sure what you're asking, but there's a triage nurse, which is the first nurse that's seen. There's a bedside nurse that's seen. Usually there's a resident physician who is a qualified physician, but in residency training, usually a 3 or 4 year training process as a physician who's seen. And there's a pending physician, myself or someone else in the emergency department who's overseeing the care. We do have some advanced practice providers in our emergency departments, both a physician assistant and a nurse practitioner who sometimes take care of patients, sickle patients. So those are the roles. There are medical assistants who do quite a bit of work as well, but they're not directly involved in determining your care. They more are help executing whatever care we have decided that there is. So those are usually the roles. We do have 2 social workers in our emergency department. They don't do a lot with sickle specifically, but they certainly have access to the other social workers who can help. So if you have social work needs, if we have housing needs, if we need to find a ride for you, our social workers can assist with that as well. But a little bit different role than they have in other places.
Yeah, we also have the 24/7 hematology consult service. It's very ED will contact the hematology consult service up front, but if the patient gets admitted and it's a complex case and we're concerned about whether the patient is going to the ICU or if they're going to need urgent transfusions and things like that, it's always a possibility that the emergency team will reach out to us, and we are also part of that process.
That's the other piece that I didn't really mention, but the admission process from our emergency department to our inpatient is much smoother than it would be if you were at another hospital and had to be admitted to University of Washington. The transfer process is very challenging. Some hospitals are capable of doing inpatient care for a sickle cell patient, but it's not going to be the same level that you get with our care. So that would be another push from my standpoint. And I don't make a dime on the number of people who come in the door. This is not a funded endorsement. I just think it's the best care because of our connection with Fred Hutch and what we're doing. Foxy has another question. Have you seen a higher need for Narcan in the ER with sickle patients after getting too much meds? I will tell you that I have never seen a need for Narcan in the emergency department for a sickle patient from too much meds. And what I mean by that is our care plans are carefully followed and we don't give too much. We give doses that are very high for a person who has not used narcotics before for pain control, but we have not had an issue that I know of where we've had an overdose in the emergency department. We certainly are seeing many, many overdoses in the community with fentanyl in the community the way that it is. I think all emergency staff, physicians, doctors, MAs, all carry Narcan in their car now because we just see too much of it. But we have not seen an increase with sickle patients specifically. Should you be worried if Narcan has to be used? Yeah, absolutely. You have to be worried if Narcan has to be used. Narcan means the patient is going to die. You only use Narcan really if the patient is not breathing enough, and you have to get them breathing, and then you have to follow and find out why that happened, what the dose was, what medication it was, not just with a sickle patient, but with anyone else. All of you, everyone, sickle parents or not, should have access to Narcan. We live in a time where there is too much opiates in the world, and this is my soapbox, but you don't want to be the person who drives by somebody who's passed out on the road when you could have saved their life. Narcan is free. Narcan is not necessary to get a prescription. Narcan can be had by anyone. You just have to ask for it.
Angela? Oh, you're muted. There you go.
Yes. Can you hear me?
There she is.
Thank you. So just two things. One, talking about Narcan, just a little caveat. So at Seattle Children's, we sometimes use Narcan not for people who are over sedated, but kids who are having issues with itching from opioid use and nothing else is helping. We give it at a very low dose. So just for everyone to know that if you come in and we are using naloxone or Narcan, it's not because we've given too much medicine, but it's sometimes used for other reasons. And then my next thing to say is that this is really great, Ms. Makela. So when we are talking to our patients and preparing them for transition from Seattle Children, for me, I would talk about myself. I don't remember bringing up what their experience would be when they transition to the adult world. And of course, it's because I've never had exactly how the process and everything goes on there. So this is really good to know so that we prepare them, because in the past we've had kids who have gone and then have come back to SCHED because they've reported waiting for too long. I was not seen on time. So this is really good to know so that when we're preparing them, we add it to things that they need to think about when they transition. So thank you so much. This is great.
You're welcome. I think I would have a hard time leaving the warmth of children's. We see this with children with cystic fibrosis as well, which is a very similar idea that they are loved and cared for essentially from birth, and now they're an adult and they don't have that place that they're so comfortable with, and it's very hard to leave that. I understand that. In the past, we have tried to do tours for people who are transitioning and walk them through the emergency department and show them a little bit of the madness, show them the room they will be in, show them how we function, just to make that a little bit more comfortable. I know that the current leadership in the emergency department would be happy to do that again. It's just hard to schedule things because everyone is so busy, but we would love to do that. I'm very understanding about how big of a change it is. It is a very scary place.
We have another question. If you have concerns about your care in the ER at the UW or any other ER, who should a patient reach out to, and what should the patient expect next?
That's a tougher question to answer. I can answer for our emergency department. And that is, well, really at any hospital, there is a mechanism for you to make a complaint. There is always a way to get to a customer service person who can make a complaint. If it's right now, then you always need to ask for the attending physician. There is always an attending physician in an emergency department who is responsible for the care, whether that care is being performed by someone in training. There's always an attending physician, and you have that right to talk to them about that care. If it's care in general, meaning I had to wait too long or I didn't like the way this person treated me, it may not be better to address that day. Maybe you should file with the customer service people, and we can look that up, talk to people, find out what was going on. At other hospitals, that's all I can really offer you is to make that complaint. If you let us know about another hospital, we can make a reach out and say, well, can we talk to you about how you care for sickle people? The problem is it becomes a very rare event. For a patient with sickle, who there are frankly not that many in this state, to end up in the OMAC hospital is a very rare event. And so it's hard for us to get into the other emergency departments and say, this is something that you need to know about. For you, unfortunately. At University of Washington, we will get back to you about any complaints. When I was the medical director, I would do this routinely, not just sickle patients, but all patients who complain. We get back to you and let you know what happened from that. There are more formal complaint measures. You can go to the state. The Department of Health investigates all hospitals, and if there's something that you think is egregious, you can certainly complain to the state, and they will investigate. I can tell you those are very formal investigations. I've been through those as well, and that is an option to you.
Yeah. Personally, I've had some success in providers who were seeing a sickle cell patient of mine far out in the state, and they managed to reach out to our services. The UW provides support from like by phone to provide from provider to provider, so providers are able to reach out to us. Sometimes they reach out to us to just transfer the patient, and that's how they get to us. But either way, like even if they're uncomfortable enough treating a patient with sickle cell disease that they want to transfer the patient, then maybe first that would be the thing they should do. And second, that's the way I've been looped in about a patient of mine who was somewhere remote, and they didn't know what to give. They were unsure of the doses, and the patient was telling them all their story about the care plan, and they didn't really accept that. So that was a way, like I've had more often than not, my patients just ask the ER person to say, hey, can you please page the UW hematology or someone and see and discuss my case, because they know what I usually get. And I've had some success guiding providers when they were seeing a patient they were not used to seeing sickle cell disease patients. So of course, like it's hard. Not every provider in every ER out there is going to take the time to page someone and discuss a case because they're also like busy with other cases. I understand the problem. But I think that would be a way out if we think like before the relationship gets sour, before things don't go well, like maybe say, look, I'm seeing at this hospital, this is who my provider is. Can you please reach out to them? Because they can give you more exact pointers on how to treat me. And I think that's always a fair request from a patient.
I agree. And I'll tell you where the resistance comes from. And I know we're just about out of time, but when a patient walks in the door and tells me that they need to have a 2 milligram dose of Dilaudid, it immediately puts me on the defensive. I'm being told how to provide medicine, and that no doctor likes to hear that. But it's a dangerous dose. And so 2 milligrams for me, who's opiate naive, it would put me down. I'd be unconscious. But for someone who had it before, someone who takes opiates on a regular basis, this is not a dangerous dose. So from an emergency physician standpoint, that's what the resistance is. They are not trying to say you're a bad person. They're not necessarily trying to say you're drug seeking. They're just scared about the doses that you have had. And so what Kleber's saying is what I said also, and that is, let us give them some assistance. Let us give them some reassurance that for this patient who we know well, 2 milligrams is just fine. and that usually goes a long way. I've had good conversations about it.
Well, I think with that, I'm happy to wrap this up. And Angela, if you'd yeah, I think if you'd like to make some final remarks, I think that would be great. Thanks, Martin, again for
Absolutely, I'm always here.
All right. So this has been really, really great. Even though what we initially planned didn't go as we wanted it to, but we're really grateful that for the families that have shown up and for all our speakers who were able to make it as well, and everybody on the line. This has been amazing. We've been able to talk about mechanics of transition, talking about what actually goes into it and what needs to be done to get it to be a success. We also talked about what mental health that affects our patients, what actually causes them to have these things, and how we can better manage it so that they can have a successful transition. Dr. Kleber talked about the disease management, went into detail about how each therapy works, which is amazing, and then a refresher course for all of us, which is really good. And then lastly, we heard about emergency care when our patients transition to the adult world. And it's really great to know exactly what the experience may be when they go there, and kind of to all this to kind of help prepare our patients for a really successful transition. So overall, again, I would want to really appreciate each one of you for joining us. And we are hoping to plan a really, really great one the next time, where we get to meet everyone face to face. We probably get to tour FACHE, the adult unit, maybe the ED, to get all the kind of a personal view of what we are talking about. So this has been amazing, and I would like to thank everyone for this.
Thanks, Angela. Your words are mine. I'm really glad with how this turned out, and I'm looking forward to the next one already. About the tour, I think we've posted the link to the survey. If you're interested in touring the FACHE, please fill in the survey. We wanted to still organize can tour, and that way they get a better sense of our clinic. Yeah, maybe it's a little scarier in the same way that the ED is, but it's always nice to be able to to host people there to make sure that they're comfortable with our clinic. So definitely, yeah, fill in the survey, and we're happy to facilitate that too, because that was one of the biggest bummers of the change in the event. In any case, just a reminder, these recordings will be also available. We'll send links to everyone who registered. And yeah, and with that, I think we can call it a wrap.